So the topic for today is TE of mitral valve. So in this masterclass, we are going to understand the anatomy of the mitral valve and identify the standard views for the mitral valve, learn about mitral regurgitation and mitral stenosis. Few first slides are just the revision of the previous lecture. So mitral valve is a complex structure. Its components are the annulus, the annulus, the leaflets, the chordae tendineae, the papillary muscles, and the LA and LV also contribute to the function of the mitral valve. Now there are two leaflets of mitral valve. You have the anterior mitral leaflet. You can see this is the anterior leaflet. It just occupies 1/3 of the circumference of the annulus and its surface area is almost 2/3. And you have the posterior mitral leaflet, which is a very small one, and although small, it occupies 2/3 of the circumference and 1/3 of the surface area. The two leaflets meet at the anteriorly at the anterior commissure and posteriorly at the posterior commissure. Now the mitral annulus is a three-dimensional saddle-shaped structure. If we eat chips, you can make out from the shape of the chips that it is a similar structure. The low or the apical axis is along the intercommissural line, and you can see this in the mid-esophageal mitral commissural view, and the high or the basal axis is along the anteroposterior line, and this is seen in your mid-esophageal long axis view. And whenever the mitral valve dilates, it dilates in the anteroposterior direction. So this is the place where we measure the annulus of the mitral valve. And the shape of the mitral valve is continuously very dynamic. It changes shape during systole. It maintains its saddle-shaped structure, whereas in diastole it becomes more flatter and planar, and it moves towards the apex. Now coming to the orientation of the mitral valve, in the anatomical view, you see the mitral valve as it lies in the body and you are seeing it from the above. Okay. In TE, we see the mitral valve from behind. So it appears rotated 180 degrees compared to the anatomical view, and the surgeon's view is the one where the surgeon is standing on the right side, and when the LA is opened, he sees the anterolateral commissure to the left, posterior medial commissure to the right. So this is how the mitral commissure, this is how the anatomical view is. This is the anterior, posterior, lateral and medial, and you see the LA appendage is lateral. This is the anterior mitral leaflet, the posterior mitral leaflet, and the aortic valve. So this is how it is anatomically situated. This is the TOE view, where you have the probe is here posteriorly. This is a posterior medial commissure, your anterior lateral commissure. Your to the left is your anterior mitral leaflet A1, A2, A3, and P1, P2, P3. And this is the surgeon's view, where the surgeon is standing on the right side, and you have your posterior medial commissure to the right, the anterolateral commissure, the posterior mitral leaflet with its segments, and the anterior mitral leaflet. Now coming to the standard TE views, you have your total 6 views are there to evaluate the mitral valve. You have your mid-esophageal 4-chamber view, the mitral commissural view, the mid-esophageal 2-chamber view, the long axis view, the transgastric basal short axis view, and the transgastric 2-chamber view. So coming to the first view, that is your mid-esophageal 4-chamber, here the transducer is at 0 degrees, and in this position the scan plane will cut through the middle segments of the valve, that is your A2 and P2. Now from this chamber, if you withdraw the probe, then the scan plane cuts anteriorly through the A1 and P1, and you can see a small part of the aortic valve also, and advancing the probe into the stomach from the mid-esophageal 4-chamber will cut the scan through the A3 and P3. The same thing can even be achieved by your anteflexion and retroflexion. So you will see that. So here you can see your A2 and P2. If you withdraw, then you see A1 and P1 with a small part of aortic valve seen in the center, and when you insert the probe, you see your A3 and P3, or when you retroflex the probe a little bit, you can see your A3 and P3. Now the next view is your mitral commissural view. Here the transducer is at 55 to 70 degrees. The leaflet segments that are seen are your P1 to the left, to the right, in between is the A2, and to the left is your P3. Now from this position, if you turn the probe to the left, you are going more posteriorly, and you will be able to see the whole of the posterior leaflets, that is all three segments of your mitral valve. Whereas turning the probe to the right will scan through the body of the anterior leaflet, so you will be able to see all the three segments of your anterior mitral leaflet. So this is your mitral valve commissural view, where you can see your at 60 degrees you can see P1, A2 and P3. The next view is your mid-esophageal two-chamber view. Here the transducer is at 90 degrees and sometimes it goes up to 100 also. And here the image cuts through the P3 on the left ear and through the A3, A2 and A1 on the right side. And the coaptation line is cut at P3 and A3. The coronary sinus is seen on the left side of the image and you see an LA appendage on the right side of the image. So this is your view. This is your left atrial appendage. This small here is your coronary sinus and you have your A1, A2, A3 and this A3 segment is coapting with the P3 segment of the mitral valve. Now again, probe rotation at the mid-esophageal two-chamber view, rotating the probe to the right will this way to the right will show more of your A3 and P3, that is posteriorly, and your posterior posterior medial commissure, and rotating the probe to the left will bring again the whole P1, P2, P3 into view. The next view is your mid-esophageal long axis view. Here the transducer is at 120 degrees. In this view, the coaptation line is cut perpendicularly. So this is a very good view for all your mitral regurgitation measurements. And turning the probe in this position, turning the probe to the right now, instead of posterior, instead of anterior, you will see more of your posterior commissure and the coronary sinus and the P3 and A3 segments, whereas turning the probe to the left will show your anterolateral commissure P1, A1 and the left atrial appendage. So the anatomy in long axis is a little bit opposite of the previous two rotations. So this is your mid-esophageal long axis view. This view is you should not see papillary muscles in this view. So that means that it is your proper long axis view. The next view is your transgastric basal short axis view. Now you have gone into the transgastric position. Always maintain an antiflexion. Without antiflexion, you will never get transgastric views. The transducer is at 0 degrees, and in this view, the mitral valve is seen en face with all 6 segments of the mitral valve available to see, as we discussed earlier. The next is your transgastric two-chamber view. That is, so from your transgastric basal short axis view, you increase the multiplane angle to 90 degrees, and what you get is your transgastric two-chamber view. This view is nothing but a flipped or a rotated mid-esophageal two-chamber view, and you can see the PML in the near field, the AML in the far field, and you can get a clear view of the papillary muscles and the chordae tendineae. This is anterior lateral and this one is your posterior medial papillary muscle. So this is one practical tip. Whenever you examine a mitral valve, always zoom or reduce the depth. Bring the mitral valve into the center. When you are examining the mitral valve, you don't need to see the LV which is below. So just increase the depth so that your mitral valve fills up the whole sector of your scan, and keep always the mitral valve in the center, and always use color compare so that whenever you put color Doppler, you can see the morphology as well as the color Doppler effect simultaneously. And one more thing, whenever you are lost in any mid-esophageal examination, always go back to 4-chamber and restart the examination. The same holds for transgastric. If you are lost in any of the transgastric views, you should always come back to transgastric mid-papillary short axis view. So this is I'm this way. I'm going advancing the probe inside. On the right on the left of the image, I can see the aortic valve. So these become my A1 and P1. As I advance the probe inside, I can see the A2 and P2 segments, and when I go inside, now I can see the coronary sinus, the longitudinal structure. just a little bit, when I come above from it, I can see the septal leaflet of the tricuspid valve and the mitral leaflet at the same level, and this becomes your A3 and P3 segments. So if the septal in your 4-chamber you have the posterior leaflet of the tricuspid valve, if it is a little bit lower or it is apical compared to the mitral, then you are through the A2 and P2, and when you see the all 4 segments in the same level, then you are at A3 and P3. Okay. So with this, always bring mitral valve in the center, as I said. Now once you have achieved this view, you should always keep the probe static. Okay, you don't have to move the probe at all. What you have to move is only the multiplane angle. Okay, so now I am increasing the multiplane angle. So here I can see my mitral commissural view with P3, A2 and P1, P3, A2 and P3. Center is the A2, on the right is the P1 and on the left is the P2. P3, sorry. Now increasing the multiplane angle to 90 degrees. I can see now my LA appendage and coronary sinus. So this is my proper 2-chamber view. On the right side, I can see the whole anterior leaflet, A1, A2, A3 segments, and A3 coapting with P2. So now just when it is in diastole, it is showing a straight line. So that means that I am a little bit deeper. So I just need to come out a little bit and show a proper coaptation. Okay, so this will be a proper coaptation. Okay, so the next angle is your increase the multiplane angle to 120 degrees, and I get my midesophageal long axis view. Okay, this is my A2 and P2. Here the scan cuts perpendicular through the coaptation line. Okay, so that was. Now coming back to mitral commissural view. Okay, this is my mitral commissural view. Now if I turn the probe to the right, it's not showing that good. You can rotate the wheel. Yeah, this one. So this is showing more of your which segment? I'm turning the probe to the right from in mitral commissural. So right will show more of anterior. Okay. Now again I'm coming back to my mitral commissural and going to the left. It will show more of posterior. Okay. Same thing happens even in the long axis. So this is my long axis. I'm turning it to the right. So now in this case, when I turn more to the right, I see anterior. Anterior. Because in relation to LVOT. LVOT. And to the left, I will see. Now LVOT has gone out. LVOT has gone, and you can see the coronary sinus coming into the picture behind there. Yeah. So you are seeing more of the posterior part. Okay. So that completes our examination of the normal valve. So going to the discussion of the mitral regurgitation, whenever we have mitral regurgitation, we are faced with 4 questions. Where is the lesion on the mitral valve? What is the mechanism of the mitral regurgitation? Once we define that, how severe is the MR and how we can help the surgeon, whether in saying that the valve can be repaired or not. So where is the lesion on the mitral valve? We can find out from all these maneuvers which we have done till now. Now coming to the mechanism of the mitral valve, the most commonly used mechanism to find out the cause is your Carpentier's classification, which is based on your motion of the leaflets. Now the motion can be normal, or it can be excessive, or it can be restricted. Okay, so type 1 is also known as normal, where the type 1 is where the motion of the leaflets is normal, and the problem lies either with the left ventricle, that is your there is ring dilatation, ring dilatation, annulus dilatation, maybe suppose of aortic regurgitation, the LV is dilating, so you will have your and mitral annulus dilatation, or there is a perforation in the mitral valve, or there is the cleft. Okay, in this case the direction of the jet will be central. Okay, now coming to the type 2, that is your excessive mitral regurgitation, where there is excessive movement of the mitral valve. It can be due to your chordal rupture or elongation, papillary muscle rupture or elongation, and in this case the eccentric jet, there will be an eccentric jet, and the direction of this eccentric jet will be on the opposite side of the affected leaflet. So what does this mean? So if your PML is affected and there is excessive movement of PML, then the jet will be on the AML, and vice versa. If AML is affected, the jet will be on the PML. Now coming to type 3, it is restrictive. So what it means is that there is restriction to the movement of the mitral valve, and it is of two types. In type 3A, there is restriction during systole as well as diastole, which is commonly seen in your rheumatic heart disease, and there is restriction only in systole, which is again the causes are ventricular dilatation, post ischemic, any ring dilatation, or any mitral regurgitation in the face of normal mitral leaflets, along with in the setting of ischemia, is known as post ischemic MR or ischemic MR. In this case, the jet will be eccentric in nature and will be on the side of the affected leaflet. So if your PML is fixed, then the jet will go over the PML. If your AML is fixed, the jet will go over the AML. So that is how morphologically you will be able to determine the mechanism of the MR. So this is an example of ring dilatation. You can see the mitral valve annulus is quite dilated. There is a small coaptation defect in the center. The LV function looks quite good. Okay, so this is type 1 MR. Here you have a cleft in the A2 region, which is commonly seen in congenital heart disease. So this will have a jet. If you put a color Doppler, you will see the jet coming out of this region. This is a perforation of AML because of endocarditis. You can see a big gap here. Okay, so there is perforation goes in type 1 MR, and there is a torrential MR or a very big jet of MR occurring through the perforation. So this was an emergency patient. This patient was planned after 2 days, was on antibiotic therapy for endocarditis, developed a perforation, went into acute MR failure, and we had to take him up on emergency basis. So now coming to type 2 MR, which is excessive motion. So there is always a confusion, what is billowing, prolapse and fail. 3 questions which always confuses us, 3 questions which are always asked in exam also. Okay. So I remember is that billowing, B involves body of the leaflet. So BB, that is where. So in billowing, the part of the leaflet body is above the annulus. As you can see, the red is the annulus. The body of the leaflet is above the annulus, but the coaptation point is below the annulus. So that is your billowing. Now in prolapse, the body and the leaflet tip, both of them are above the annulus during systole, which prevents leaflet coaptation, and the leaflet tip still points towards the LV. You can see here the leaflet tip is pointing towards the LV. And in flail, you have the leaflet tip above the annular plane and it points towards the LA. So this is associated with chordal rupture or extreme chordal elongation. So this is the tip which is pointing towards the left atrium. So this is a proper flail segment of the mitral valve. 2 things again very common: fibroelastic deficiency. So what is it? So it is basically a degenerative mitral valve disease which is characterized by deficient fibroelastic tissue in the posterior annulus, especially in the P2 region. That is why the P2 prolapse is very common, and the next common prolapse is your P3. Here you have your normal leaflet thickness. There can be an isolated prolapse. Flail is common. There is eccentric MR. You have thinned out or elongated chordae, and you may or may not have annulus dilatation. So here you can see there is a P2 prolapse here, and Deepak has also showed very good images. And in this case, big coaptation defect here, and you can see the big jet going through eccentrically over the anterior mitral leaflet wall hugging the LA. The next is Barlow's disease. So Barlow's disease is nothing but again a degenerative disease of mitral valve, which is characterized by your myxomatous deposits in your mitral valve. Because of these depositions, the leaflets become thick. There are multiple prolapses. Okay, just not a single prolapse, but multiple segments of the mitral valve start prolapsing. As you can see in this image, you can see almost all three segments are prolapsing. There can be central or eccentric MR depending on which prolapse is prominent. There is always annular dilatation, and there is so much of tissue in the mitral valve region that the whole annulus gets displaced into the left atrium, and there are usually thickened chordae. These are the kinds of cases which always go for replacement rather than repair, or maybe a very well experienced surgeon can repair a Barlow's. Not everybody. This is an example of P1 prolapse where you can see this is your A1 segment because the aortic valve is seen here. So this becomes your A1 segment, and this is the small P1 segment through which is prolapsing, and there is a jet on the AML. This is an example of ruptured papillary muscles where in between you can see a small circular structure coming, which is your ruptured papillary muscle. And always the posterior medial papillary muscle is the most common to rupture because of its single blood supply. Okay, this is an A2 segment which is flail. This is your AML, long axis view. You can see a flail segment here, and when you put color Doppler through it, you can see a jet over the PML along the posterior LA wall. Okay, now coming to type 3A, that is rheumatic. In type 3A, there is restriction both in systole as well as diastole. You can see here there is a thickened leaflets, and they are not ready to coapt. Whatever, this is the normal motion, just motion occurring this way, and there is a gap in between through which you have your mitral regurgitation jet going on. Now type 3B is your ischemic MR or your functional MR. Okay, now because of the enlargement of the LV and the apical displacement of the papillary muscles, your leaflet gets pulled down, and they don't come up to the annulus plane for coaptation. So whenever there is equal restriction of both the leaflets, then there will be symmetric tethering. So you will have this kind of a picture. Whereas in asymmetric tethering, as you can see in this case, only the P2 is only the posterior mitral leaflet is static, it is not moving at all, and your anterior is quite moving. In this case, you will have an eccentric jet over the PML, and in symmetric tethering, you will usually have a central jet. Okay, so this is your symmetric and asymmetric tethering. Now there are certain measurements which we do, that is your mitral valve annulus, your AML length, your PML length, your C-sept distance. C-sept distance is the distance from the coaptation point of the mitral valve to the interventricular septum. In cases of excessive MR, to assess feasibility and predicting the successful outcome of the repair. And in cases of restrictive MR, you do tenting height and tenting area, where a value of more than 1 and a value of tenting area more than 2.5 is considered as a difficult repair of the valve. But in any of the cases, if you have a very dilated annulus, that is in the range of 50 millimeters, or too much of calcification, or there are multiple prolapses, these valves cannot be repaired anytime. You have to go for replacement. So this is all the information which you have to give to the surgeon regarding the morphology. So the next question is, we have seen all the morphology, we have defined the mechanism of MR, we have found out from where is the MR. Next question is, how severe is the MR? So this can be done in two ways. One is your qualitative, another is your quantitative. Qualitative is nothing but just eyeballing the mitral valve in 2D and your color Doppler. But remember, always optimize your haemodynamics before assessing the severity of MR. So this you can do either with your phenylephrine or noradrenaline, whichever you are using, and fluids. It's just not vasopressors. You need to use fluids also, and but optimization till how much level. So what we do in our place is we get the blood pressure up to the pre-induction level, and then we assess the MR. Strict conditions. So in that, once you have achieved good hemodynamic conditions, first thing is you look at the morphology of the mitral valve. Whatever we discussed in the previous slide, you start looking for all those things. Okay. Second is your coaptation line. So this is the coaptation line of a normal mitral valve. If this is the coaptation line, you have a good coaptation distance, so you have less reserve for MR. So this will not be at a very high risk of MR, whereas a mitral valve which is coapting this way will have a high risk of MR. So any increase in LA pressure will suddenly LV pressure will suddenly increase your MR. So that thing has to be noted. So once you have completed the examination of the mitral valve, you go on the other structures. You look at the size of the LA, whether it is dilated or not. You look at the LV size. An LVIDS of more than 40 millimeters suggests dilatation and dysfunction. You look at the apical displacement of the papillary muscles. You look at the increased interpapillary distance in your transgastric short axis view, mid-pap short axis view, and a value of more than 20 millimeters is suggestive that this valve cannot be repaired that easily. Once you have done all these things, put a color Doppler and see the jet. First thing in jet you see is how big is the jet, how much is the jet causing increasing the area in the left atrium. You look at the direction of the jet, whether it is central or eccentric. The eccentric jets, they always show a Coanda effect. That is, your fluid jet will get sucked against the wall of the LA and it will make it appear small. So an eccentric jet is always severe unless otherwise proved. So this is all about your qualitative examination of the mitral valve. The next thing you do is you put a continuous wave Doppler on the MR jet and you look at the density of the continuous wave Doppler. In mild to moderate MR, you will have an incomplete envelope. Okay, and it will be early systolic. So you see the maximum envelope is here, and then the MR starts fading. So this shows that it is not a severe MR. Whereas in severe MR, you have a very dense profile, and this dense profile means that more and more RBCs or blood is going into the left atrium during the systolic phase, and you have an early peaking envelope. So this was the start of the systole here, and in this much time it has already peaked. So there is a huge MR there, and it is usually throughout the whole systole or pansystolic. So this will give you an idea about the severity of the MR. Now the transmitral pulse wave Doppler does not quantify, but it acts as an adjunct to show where a dominant A wave will rule out severe MR. If you have a dominant A wave, there can never be a severe MR. So whereas a large E wave in the range of 100 to 120 centimeters per second will suggestive of moderate or severe MR. But why there is large E wave? Question is that it is because of the increased velocity which is occurring in the transmitral region. So that produces a large E wave. So you get an indirect idea if there is much more flow. So it can be because of severe MR. Now comes the most interesting part, that is quantification of MR. So whenever, it took me long time to understand this concept. So whenever the blood approaches a leaking orifice, it starts crowding. Okay, it starts crowding, and as it starts crowding, as it reaches towards the orifice, the velocity also increases, and once it passes through this area or through this leak, it produces a huge jet, and because of this jet, the chamber in which it produces can produce back pressure changes in the other organs. So this crowding of blood is known as your flow convergence, and it produces your hemispheric sphere. Shells, hemispheric shells, and this flow speeding up of blood is your flow acceleration, then you get a jet and you get the black flow. So how do we use this for quantification of MR? So your flow conversions and your hemispheric shells will give you an idea about the pisa or the proximal isovelocity surface area, which will be used to calculate your effective orifice regurgitant area and your residual volume. Vena contracta will be measured at the narrowest point. Then you will see the jet, and you have your pulmonary venous flow, which will measure the back pressure changes. So let us see one by one. Okay. So we all know that the normal pulmonary venous profile has a large S wave which occurs during systole and a small D wave followed by a inverted AR wave, which is nothing but your atrial contraction. In mild MR, you will get S and D wave almost of the same size. In moderate MR, there will be systolic blunting of the S wave, and in severe MR, this systolic blunting which was there will reverse and will produce a systolic flow reversal. So here you see in this case, S wave is larger, equal in size, systolic blunting of S wave and reversal. So very important in this is your ECG. You need to have ECG to detect your systolic flow reversal, because there is another wave, that is your AR wave, which is also below the baseline. So this is your systolic flow reversal in left upper pulmonary vein. You can see this is my systolic phase till here, and here you have your systolic flow reversal. Similarly, in right upper pulmonary vein, you can see systolic flow reversal. Okay, so it is a very specific sign for MR, so that should be kept in mind. So if there is systolic flow reversal, there has to be severe MR. Next is your vena contracta. This is the narrowest portion of the jet which you measure, but one should always keep in mind that you need all three components of the jet. That is your flow convergence, which you see here. This is your flow convergence, the neck and the jet flare to measure correct vena contracta. Okay, where a value of less than 3 millimeters is mild and more than 6.9 more than 7 is severe MR. So vena contracta is a very simple, easily reproducible method. It is independent of loading conditions, so that it is a very useful parameter to use. But one should keep in mind that it is not useful in multiple jets. If you have multiple jets, then you have to locate the origin of each of the jets, which segments are collapsing, and when you have multiple jets, multiple prolapses, automatically it goes in favor of severe MR. So that is how you come to the conclusion. Next is the effective orifice regurgitant area or residual volume. How do you do it? So first you need to have a good zoomed view of mitral valve color Doppler. Okay, so here you see this is a big jet coming out. This is my Nyquist limit. Okay, now I shift the Nyquist limit, baseline of the Nyquist limit in the direction of the jet. What does this mean? The jet is occurring this way from LV to LA. So here I will shift to around 38 or 40. You can do it 40 also, you can do it 38 also. I am trained in doing it 38. I don't know why, but that is how we were taught. Okay. Now next is you measure the length, measure the radius, that is from the effective orifice regurgitant area to the first aliasing velocity. What is aliasing velocity? The velocity at which there is color change. So here you see there was a blue color and it has changed to red color. So this is my first aliasing velocity. Okay, I do a pulse continuous wave Doppler of the MR jet and I get my two values, that is my Vmax and my Vti. Now I calculate effective orifice regurgitant area as 2 pi r square into aliasing velocity divided by Vmax of the continuous wave Doppler. In this case, it comes to 0.45 centimeter square. And this value, when multiplied by the Vti, will give you your regurgitant volume. Okay, so here an effective orifice regurgitant area or an EROF less than 0.2 is considered as mild, and a more than 0.4 is considered as severe. But remember, in functional ischemic MR, an effective orifice regurgitant area of more than 0.2 or a residual volume more than 30 ml is also considered as severe MR. Why? Because of the shape. the residual MR is usually the MR in ischemic MR is the orifice area is usually elliptical. So it is that way. Now coming to the advantages of EORA, it is very useful in central jets. You should do it in when you have good image quality. Okay, and whenever there is a doubt, how much is the MR? See, for mild and severe cases, you are not going to do this EORA. It is only for the moderate cases where you will do your EORA measurements. Okay, so one should keep in mind many limitations, because here it assumes a functional circular shape of the EORA, which may not be the case in all MRs. Again, if you do error in measuring your radius, this error will be squared. Okay, and of course it is time consuming. It is not that easy in a where a very fast surgeon is there, and if he goes on bypass in 15 minutes and you are still doing your measurements, then in that case it becomes very difficult. So only in cases of dilemma, or where the pictures don't match, you will go ahead with all these quantification methods. But it is the only advantages that it is the only quantification method available for MR. So this is the whole table of what we discussed till now, available in all textbooks. And I'm sure once you read this after this lecture, this is going to be very easy. And mild and severe cases, as I said, don't require any much efforts to quantify. It is the moderate where you have to do everything. And when you apply each and every parameter, always think about its disadvantages. LCx examination, that is your left circumflex. So no discussion of your mitral is over with if you don't discuss about left circumflex examination. So as we know the anatomy, the left circumflex artery, after its division from the left main, runs in the AV groove, and it is closest to the annulus in your P1 and P2 region, and this is the place where it is most prone to injury. Why it is important to know the dominance if you are doing, because if your circumflex is dominant, you can see in this image, it runs along the entire course of the posterior annulus and it supplies a large chunk of myocardium. So if this gets compromised, then your patient is going to land up in problem. Now this is the way we image circumflex artery. You take a good zoomed view of the mitral valve of the mediastinal long axis at around 110 112 degrees, and once you have this kind of image, you start turning the probe to the left so that you will see more of posterior structures. So here you can see the bifurcation occurring here. This is the circumflex, it is going this way, it will go. Okay, once again, this was the bifurcation here. This is the left circumflex going this way. Another structure which comes from the opposite side is your coronary sinus. That also can be seen in this. Okay, so this was a bifurcation. Now I think everybody could see the bifurcation. Yeah, and this structure was coming from here. Now see the coronary sinus. It is coming. It is circular. Now it becomes longitudinal and it goes in this direction. At some point they crisscross each other. When you apply color Doppler at a Nyquist limit of around 20 to 25, you can even see the flow in the circumflex artery. And when you assess in the post-CBV period, it is always said that you assess the circumflex before the heart starts beating, so that you can see the flow properly. Okay, that is all about circumflex artery. The other things you have to see why in a mitral case is examination of the aortic valve, especially if there is any pre-existing AR or not. Because if there is an AR, because there is always a chance that the non-coronary leaflet of mitral valve gets sometimes taken by the surgeon during the repair or replacement, and it can cause AR. And if you don't know whether there was AR before, then it becomes difficult to comment on that. So that ends the discussion for mitral regurgitation. So now you can see, can anybody tell me what leaflets of mitral valve we are seeing? What segments, I mean? A1, P1. Both are looking coapting properly. Now we start advancing the probe inside. Something has happened. So Prolapse. Why prolapse? Because the segment is above the plane of annulus and the leaflet is pointing towards the LV. So this is a prolapse. Had it been flail, it would have pointed up this way. Okay. Color. So next thing, once I have found out that there is P2 prolapse. Okay. Now I have to examine one more segment, that is A3 and P3. So I will just go down a little bit and see. Here I can see there is good coaptation. Okay.
And at the tricuspid level is the same.
Same.
So you are more posterior.
So my A3 P3 is normal. So this is my isolated P2 prolapse. So once I am done with this, I will come up above again. Once I have examined the morphology, the next step what I do is put a color Doppler. Okay. So now you put a color Doppler. So when you put a color Doppler, what you see is an eccentric jet. Over AML, affected segment is PML. So this is type 2 MR. So I have found out the location of the MR, I have found out the mechanism of MR. The next thing is I have to find out the severity of MR. So again, eccentric jet goes in favor of severe MR unless otherwise proved. Okay. And vena contracta would be the best method in this cases because it is useful even in eccentric jets. Never use EORF for eccentric jets because your continuous wave Doppler will not have a proper alignment and it will give you less Vmax and VTI. So your values will be on the lower side. But eccentric jet, again, it rules out mild or moderate MR. Next thing is, fourth question is the valve surgically repairable or not? So I have seen A1 P1 normal, A3 P3 normal, only P2 segment affecting, only one segment is affecting. The leaflets look quite thin, other leaflets are not affected. So this can be repaired by an experienced surgeon. So by this examination, I can answer all my 4 questions. Once in this, I will go in the next thing. What I will do is I will go in the long axis. Okay, so this is my long axis. So here I will do certain measurements. In diastole, I will measure the mitral valve annulus, the length of the anterior mitral leaflet, the length of the posterior mitral leaflet, and the C-sub distance. So these are the measurements which I will do in my mitral valve area. If these are favorable, then we can say we can repair the valve. And a C-sub distance of more than 2.4 centimeters again rules out that there is less possibility of SAM occurring in the post-operative period. It's not, there is always a possibility, but there is less. C-sub more than 2.4 small posterior mitral leaflet will always help you prevent SAM. So the next discussion is mitral stenosis. Mitral stenosis is not as vast as mitral regurgitation. So in mitral stenosis, what you see in morphology is your restrictive leaflets with diastolic doming. That is your characteristic hockey stick appearance. This is because both the leaflet tips are fused along the commissures and only the free body of the leaflet is moving. So that is why it produces a typical hockey stick appearance. You can see thickened calcified leaflets. You will see subvalvular thickening and calcification. A severely enlarged LA. You can see this LA, how big it is. Okay, and you will see spontaneous echo contrast in LA, and slowly there will be clot formation in the left atrial appendage. Second thing, what we don't very commonly see in our country is your degenerative mitral stenosis. The hallmark of degenerative mitral stenosis is your mitral annular calcification. It spreads from annulus to the leaflets. Rheumatic spreads from leaflet to the annulus, and degenerative calcific MS spreads from annulus to the leaflets. There is valve thickening and there is no commissural fusion. This image, this is a proper mitral stenosis. This image, if you see, there is no stenosis as such, but you can see a big chunk of calcium on the posterior mitral leaflet, and this over years will start progressing towards the center and produce stenosis. Coming to the evaluation, You measure the opening area of mitral valve by direct measurement or planimetry, or by calculation of continuous wave Doppler using pressure half time. You measure the mean gradient and you measure the systolic pulmonary artery pressure. Now in mitral stenosis, the mitral valve becomes like an inverted funnel and the narrowest area is at the tip of the leaflets. So it is important to find this narrowest area. So you need to scroll up and down to find the correct area. I have never found out till now, because there is always so much of calcification and shadowing that it will, you'll never get a perfect image, and you need a proper circular image of this kind. If you have an oblique or an oval image, that means you are cutting a little bit above the valve, and if you start having chordae, that means you are much below the valve into the LV. So you have to be very good at scrolling the valve up and down to measure this. So the next way of measuring is your pressure half time. That is the time taken for the transmitral gradient to fall to half of its initial value. So 220 divided by pressure half time gives you your mitral valve area. It is easily obtained from your continuous wave Doppler of your mitral valve. So from the this peak you measure till this point and you get your pressure half time. In this case it is 268. Sometimes the pressure half time is bimodal. So you have initial rapid fall followed by a gradual fall. So in that case you take the mid systolic gradual fall for your pressure half time. This line, if you extrapolate below, you will get your deceleration time, and 759 divided by deceleration time will also give you your mitral valve area. But remember this, if your LV is already non-compliant, then this method will again overestimate the mitral valve area. If you have associated AR, there will be shortened pressure half time because the LV is getting filled from both the sides. So it will achieve your pressure half time very fast. So you will overestimate the mitral valve area and underestimate the severity of your stenosis. So those things have to be kept in mind. You take the so this part you will exclude. Here you see this part you will. So from this point you will measure the pressure half time. Okay. Next is your mean gradient. So mean gradient is also easily obtainable from continuous wave Doppler of your transmitral flow, and you trace it and you get your mean PG, which is 13, and a value less than 6 is mild, more than 10 or 12 is severe stenosis. Again, mean gradient you have to take into consideration the heart rate, because if it's more tachycardia, then your gradient will be on the higher side. If there is associated MR, then again the gradient will be on the higher side. And last is your systolic pulmonary artery pressure, where you measure the TR jet velocity and add it to your central venous pressure. This parameter gives an idea about the chronicity of the mitral valve disease. And if it is high, if your PA pressures are high, then always have a good look at your RV function, because then these patients will have a lot of problem in the post CPB period with RV dysfunction. So this is the grading of the mitral valve, again available everywhere. Thank you.